As we get ready for our first panel session, a word from our sponsor, MediQuant.
Reduce costs, fortify cybersecurity defenses, and ensure regulatory compliance when you decommission legacy applications and archive your clinical, financial, or ERP data with DataArc, healthcare's leading active archive for the enterprise. Under the direction of a dedicated and highly experienced project manager, MediQuant's archiving team works with you every step of the way. We'll prepare, map, and load your data into the archive, validating its accuracy not once, but twice, so that you can confidently decommission systems and eliminate millions of dollars in maintenance and licensing fees. Archive your data with MediQuant's DataArc and experience a number of benefits, including HIPAA-compliant single sign-on access to historical clinical data within standard technology workflows, improved audits, and faster and more complete releases of information. Securely storing legacy data in a centralized repository also allows your organization to better leverage historical data using BI and reporting tools to fuel decisions. And with the ability to actively work down patient accounts and manage provider billing in your archive solution, organizations can take legacy systems offline sooner to save up to 80% of the cost of operating systems in parallel. Perhaps most importantly, by offering your users easy access to archived patient records, you'll help support more informed clinical decisions, improving medical outcomes while elevating both the patient experience and physician satisfaction. Migrate your legacy applications to DataArc's Active Enterprise Data Archive without losing your valuable data. Speak with a MediQuant data archiving expert today.
And now if you could, please take a few seconds to read the bios of our moderator and panelists.
Hello, awesome people, both on my panel and out in the world here listening. We have an amazing combined topic that could take 2 days to cover. We're going to try and do 2 topics in a very short window, so I'm going to get started. I am Susan Clark. I am a Senior Program Director for DirectTrust. And just real quick, I'd love to have my panelists introduce themselves and where they're from. So I can see Didi first. Do you want to just give us your little intro there?
Hello and good afternoon, everyone. My name's Didi Davis. I work for the Sequoia Project, a nonprofit 501c3 based in Washington, with the public mission of trying to increase interoperability for the public good. So a lot of what I'll be focused on in my capacity as Vice President of Informatics, Conformance, and Interoperability is a lot of the work that we're doing for the data usability work group, and also are taking root efforts to actually deploy some of that work, as well as some of the standards feedback that we're giving to the standards bodies. And testing, of course, holding everyone accountable to that. So I do a lot of that in my role day to day at Sequoia. Thank you for having me.
Awesome. And my friend Katherine Lusk, I see you next.
Well, I'm going to say good morning because I'm in Central Texas and it's just 11:30. So all of you in Central Texas, good morning. And all of you everywhere else, good afternoon. I'm going to tell you a little bit about what I'm going to talk about. I'm with the Texas Health Services Authority, and we're the state's health information exchange. But more important than that, we host an interoperability collaborative where we work to break down the barriers to safe, secure exchange of electronic health information in Texas. And I'm going to tell you a few of the stories that where we've uncovered wrinkles that have helped iron them out and improve data usability and data integrity in the state of Texas that have spread across the United States. So fun times ahead.
Mm-hmm. And I see Dr. Kell, are you online there to give us a quick intro?
I I am. Thank you for having us today. Good afternoon and good morning for those that are not quite at 1 p.m. My name is Pults. I'm the Chief Clinical Officer and Vice President of Government Strategy at MediQuant. MediQuant is an active archive solution company. So our product, Data Arc, is our flagship product. We have been in business for almost 25 years in 2024. We do service customers in the commercial market using our flagship product, as well as other solutions within our application portfolio. And we also work with Defense Health Agency and are their legacy vendor as well for their legacy systems as they move to their new EHR platform. So we're excited about that. And we customers on the commercial side as well. I think our big focus is helping to reduce costs, helping to reduce the IT footprint. And so we're looking forward to kind of talking through some of those interoperability things today with this group and how the archive plays a part in the designated record set and is used also in the interoperability solution overall for customers.
Awesome. And just real quick, Kel, we cannot see your face. So if you are able to turn on your webcam to join the Brady Bunch squares, that would be amazing.
I was just honestly looking for the picture, why my picture wasn't showing. So thank you.
Wonderful. I see you now. Okay. Well, we'll start to dig in. And just for me personally, I feel like data quality is that data usability has a reliance, if not a dependency upon data quality. So I thought maybe we'd start there a little bit and maybe have you describe what data quality means to you and what its implications are in this environment. And I will start with you, Kel, since I now can see your face.
Okay, that sounds great. So data quality for us, we are, as I mentioned, part of the designated record set. So when someone is looking to do release of information, they're looking for looking at the archived legacy data, which is important from a historical perspective for patients. It's important for the data to ensure that the data is good, that it's good data, that it's accurate, that just because you're moving it off of an old legacy system onto an active archive like ours, you've got to make sure that it's correct. Because providers do look at that historical. We have certain providers that are very diligent about looking at historical records. Example, cardiology, oncology, there are max doses related to medication administration, and they need to be able to look back from a historical perspective and make sure that they're looking at the continuum of patient care across the records. And so it's really important for us to make sure that the data we move into our archive is not only accessible, but it's usable and then it's reliable at the point of care. And then as we look at the designated record set, talk about the usability, it's great to have data, but when you want to move that data or you need it at whether it's release of information or you're going to send it through an interoperable method such as FHIR, that data is readily available to be able to do that. So it's kind of hard to do that when you've got offline data and older data, many years old. Obviously, you don't need it as often, but we take the legacy data that they're still needing. And so we need to make sure that when they go to access the system, that it's right there for them to be able to use and that it doesn't take days. Old school nursing here. So, we used to request the records and they would come up on a cart and it could be hours before you actually got that record. That's not acceptable anymore. People need to have the access to the data immediately when they need it. And so having that active archive is really important. And that's a key criteria for us, is not just being able to access the data, but make sure that when they do access the data, that it is exactly what they should be seeing and that it's correct.
I used to push that record cart, just by the way. Anyway, so Didi, and so to Katherine, Didi, would you like to chime in next? Oh, you're on mute. There you go.
Sorry about that. Sure. Yeah. So I think of, I'll kind of put it on definitions the way I'm thinking of it. So as you pointed out earlier, data quality is the paramount foundation for data usability by all means. I think of data quality using kind of an example of semantic interoperability. So if you use the HIMSS definition, there are 4 levels of interoperability. The 3rd level is that semantic interoperability. That's the quality. That's where the data, the discrete elements, even narrative notes are coded with some sort of vocabulary so that a machine, a computer, can take that data, harness it, digest it, and serve it up in the right workflow for that clinician, physician, or whoever is interacting with the patient doing care. So that's quality. If I think of it, the right structure, the right vocabulary coding, all of that to enable the health IT system to work as optimally as possible. When you add usability on top of that, it is really to take and also get that data into the right workflow. And I'm going to steal an example, and I won't go too much into it, but I'm going to use your example, Katherine. In the state of Texas, if you think about quality laboratory data, they did an analysis not too long ago, and she can go into more detail about that. They found that across the state, the different vendors, and even sometimes the same vendors, had ways of implementing those systems to display that data to the clinician in different ways. Some of them put it alphabetically, some of them grouped it. So something like a complete blood count or a CBC, you might want that data grouped. That's usability. So an example, not just one, that's the only way of usability, but thinking that as kind of an example. How do you streamline the workflows, change the paradigms so that the clinician can interact with that data? DirectTrust is a great thing to think about. When folks started implementing DirectTrust early on, a lot of the implementations, the vendors adopted a secure inbox. Well, that was a little bit separate from the electronic health record. It might have been incorporated in it, but they had to go to some other screen from one to the other. That's usability. How do you streamline that? How do you take that data that came in from a direct message, put it into action items in the electronic record so that it's just part of their day-to-day workflow? So that's what we think of as usability. And, you know, there's a lot to tackle there, but I'm happy to say Sequoia has been working on this since 2020, and we have some guidance that we're trying to get adopted right now. So that's my thoughts on the difference of kind of quality and usability in general.
Maybe, Katherine, what does quality do for you?
Data quality means to me trusted data. It means trusted data in the technical infrastructure and in the content. And the content's a piece that people forget because the content is controlled within the organization. However, that content does not always follow the patient in the continuum of care. So that's what data quality means to me. We have hundreds of different authors that are on many, many, many different platforms, and the standards, both technical and content, are what guide and harmonize the record so that our story is the same. Isn't it a shame that our story is incomplete and that there's batches of it missing? And that's because a lot of times people don't recognize the standards that they should employ and don't actually make sure that the record follows the person. So the medical record is really the key to all of this. And you're not surprised that I said that, are you, Susan?
No, not at all. But keep preaching. I'm here for it. Moving a little bit, I want to hear about what are some areas that people kind of don't think about when it comes to data quality. And I'm going to start with Didi on this one. Oh, you're muted again.
Sorry about that. I keep forgetting I mute myself. I just need to quit muting in between. So in my mind, some of the things people don't think about is that quality or usability in all projects. And I'm even one of those that I'm guilty of this. When I was a vendor implementing systems, I had a vendor hat 16 years long ago. I left the vendor world in 2006, but needless to say, thinking about how can we do the best for that implementation at the time, whether it's a radiology system, a cardiology system, thinking about how can we really implement that with as much possibility for configuration optimizations, making sure that you're using the code, you're training the clinician on that new workflow. The quality piece of it takes two pieces into account. capturing the data, but also making sure that that data flows on with that data that was captured appropriately. So I think of one of the things folks don't always think about is what happens if I take and translate this laboratory code to something that's my own internal code that I use in my own health system. That might be great for your health system, but when you send that data outside of the health system, thinking about cross enterprise communication, not just within your own workflows, but how am I sharing that data with others? And how can I provide the most complete? I think complete was one of the keys that you honed in on, Katherine. How is it complete and trustworthy? How do I make sure to include the right provenance when data gets transmitted? Where did it come from? Who captured it? What date and time was it captured? You may think about doing that at a document level, but also including some of those things in the discrete data, especially as the new standards like FHIR come about. You're going to need to have provenance information with medications, provenance information with allergies, with problems, with all of those different types of discrete elements. So I think the thing people forget a lot is how can we make sure that as the data is moved from system to system, that we are trying to provide the best quality of information, complete information with all of those things like provenance to make sure it's secure and trusted.
Maybe we'll go back to Katherine. I'm doing kind of an NFL fantasy draft snake.
Back and forth.
Yeah. So okay.
Well, I'm gonna build on what Didi says, and I also put a teaser out to the crowd about HIE broken. So and Didi knows this story because she participates in our collaborative. One of my members sent a message to me, and he's a primary care physician. HIE is broken in Texas. And I said, well, what EHR vendor do you have? And he has a national EHR vendor. And he said, none of these other organizations are sharing information. Well, I know the state of Texas, and I know who's sharing. And everyone who said that was not sharing does share. But they don't think he's sharing. So we sat down and we met with his EHR vendor. And you know what happened? He felt data quality was poor because when he initially implemented his electronic health record, he set it up to query at pending at 72 hours. And he was confirming all of his appointments at 48 hours. So the only thing that his EHR vendor was pulling forward were those scragglers. So hence he thought the other organizations were only sharing sometimes, met with his EHR vendor and said, we're glad to change your settings so that you can now pull all of the information. He was like, wow, this is magic. HIE is not broken. So, and I'll tell you another little story that happened just last week. We were meeting with two different organizations that exchange records continuously, and we had both of their vendors on the line. Vendors are great. People say that they don't share, but they actually do. So one organization said, you keep sending duplicates of the same visit note over and over and over again. And when we opened up those visit notes, no, that wasn't the truth. What was happening was the settings within their EHR was showing the date of the query instead of the date of the visit note. So the clinicians were not even opening up the note, thinking it was the same note over and over again. So that's data quality. And a lot of times people make decisions early on when they don't really know what they're doing, or they don't know what they don't know at that time, and they don't go back and revisit it. So I'm going to tell you more HIE is broken stories as we go forward about the lab stuff and discharge summary CCDA, but those are just two little stories.
Kel, what kind of stories do you have about what we aren't thinking about in data quality?
Well, I'll tell you what. So like Didi, I worked with EHR vendor years ago, implementing project management. And there is a big difference when you are implementing an EHR, to Didi's point, where you are focused on the individual organization that you have. There's a ton of customization that can occur, lack of standardization, because they don't realize that later on down the road, I mean, when you're implementing, there's no thought that we're going to be moving off of this in 5 years and we're going to need to put it someplace. So it was an eye opener. So I've been with MediQuant almost 10 years. It was a huge eye opener for me to start seeing systems the back end of all of those decisions that were made on the front end, trying to get that data out on the back end and seeing what it really looks like when you don't have standardization between systems, and how difficult it is. A very complex then project you have to say, we're going to move these and we're going to harmonize this data without changing any data elements, because part of making it a legal record is you cannot change any of that kind of stuff. So all of that metadata, Katherine, you mentioned lab results. You guys were talking about lab results, where you have one organization that has a facility with certain reference ranges, and you have another facility within that same organization, and their reference ranges are not the same within the lab environments, right? Because at one point, maybe they weren't even connected. They acquired this other organization and they're off by a little. We cannot change that. Whatever the decisions that were made on that record with that reference range are the legal record. Now, the decisions were made, you don't change that stuff. So the codes, when I implemented years ago, Snowband wasn't even a thing. So you can imagine, as we archive some of those systems, I can tell you that penicillin can be spelled 10 different ways. PCN, all the short, it's spelled incorrectly, all of these things that come out the back end of that. And I think what's gotten better and what I've noticed is the standardizations that have been put in place, the SNOMED codes, the LOINC codes, those kinds of things. It has been a significant improvement to what comes out the back end of that system, to be able to actually do things and use that data for HIEs, for fire, as we talk about different ways we're going to have interoperability. Those standardization efforts are very evident in the newer systems, I would say in the last 5 years in particular, as they've started to collaborate more and come up with the standards for not only how they're implementing systems, but how they're codifying the information that goes in. So when it does come out and they change, we have much, much cleaner data for those systems that are being archived now versus systems 10, 15 years ago where it was a free-for-all. And part of it was we didn't know what we didn't know, right? I mean, we're still young, and really when you look at it in the standardization across these EHR platforms, we are really young in the sense of it was a learning curve on what we needed to do to talk to each other. That though we all went to electronic, there was not I think initially at the forefront of how are we going to maybe share this patient's data with a hospital across the town or across the state, because we do see clients now that have multiple facilities across states. So it seems to be getting a little bit more complex, but I do think it has been lessons learned, not just for our HIE folks and for like Sequoia that's working on, the fire stuff with ONC. I think that for across the board, us as doing archives, that we are learning that we all have a piece of this pie. How do we make it now so it's a single record, that it's usable, that the workflow works, and that the data is right when we've got somebody that's actually taken a look at it, including our patients who access their records more than ever now.
Just to remind everybody, this is not one and done. Remember, every time you put in a new update to your system, it's kind of like if you have an Android phone or an Apple phone, when you get an app update, all of a sudden you have new functionality. Think about what can I take and harness from that new functionality and improve that workflow even. So that, helps with the quality capture, but also, the clinician burdens reduced, everything like that. So hopefully making sure everyone keeps thinking every time an IT system is implemented or updated, how can I improve it? So kind of think outside the box.
Read those release notes.
Yeah. That and add in our security, right, ladies? I mean, the security added to everything right now. There's technical debt with all of this now, and size of data storage. I mean, there's a lot of considerations that go into all of that now.
For sure.
And I think that's going to come in well to the next little topic of thinking about, there are a lot of great standards and formats. We've come a long way. We know what the envelope looks like to go from here to there. Everyone's got this same standard envelope that's going through the post office, but the letter that you wrote to put inside it looks a whole lot different. And so when it comes keeps coming across, that's where we're starting to get the changes. But how can we make that better around how, within the standards that exist? How do we make the content standard better? And I'm going to turn to Katherine first, because I think she's got a pretty great story about discharge summaries in Texas that I can't get tired of hearing about.
Oh, I mean, it is a absolutely beautiful story. The primary care physicians in the state of Texas said, the discharge summary is inconsistent. There's too little, too much, and it's different from different EHR vendors and from different organizations. And it's causing us to fall back on facts. Well, I'm not a big facts, no offense, facts vendors. I'm not a big facts fan. I believe that data needs to be ingested into the EHR and make life better for our clinicians. And you know what? So do they. So we began to look at the different discharge summaries, and they were as bad as what the providers said. Then we asked Didi to come and help us understand, why is it that hospitals have this robust discharge summary, but when a discharge summary CCDA is sent or queried against, it's so scanty or so inconsistent. And Didi came and educated us all on CCDAs and the discharge summary CCDA, so that we understood there's a minimum, but there's 70 other different options that can be included. So we then queried the community to find out, well, what are those options? We came up with the options, and you know what? They look surprisingly similar to the Joint Commission and CMS content requirements. So we vetted it through our entire community. We posted it to the ONC USCDI version 3, and I got a call from ONC. I was frightened at first. I thought, oh my, why are they calling me? Are they mad because I comment on so many things? No, the first thing they said was, have you met Didi Davis from the Sequoia Project? We can, and I said, yes, I have. We are friends. And so indeed, and actually, we put a recommendation together, and we gave that recommendation to the Sequoia Project, and it was included in their December 22 implementation guide as Appendix B. So those of you who have not adopted that, I'm going to call you out and ask you to adopt it, because we are working on that in Texas. So, and another thing we did was we worked through the HL7 structured documents thing, and it's going for vote this January to be included as a certified EHR. So that is my story about improving the content of the discharge summary.
That's awesome. And I guess I'll turn to your longtime friend here, Didi, that I think this also is an opportunity to plug, and just because I'm also a longtime FAHIMA member, so I know they're very involved with this too, on the data usability taking root or root, depending on what part of the country you are from, on how you say it. But anyway, Didi, what are your thoughts on this topic?
Yeah, so building off of Katherine's example, this is showing how the real world feedback loop can be accommodated. When we all work together to do this, we can make some changes happen. And as Katherine mentioned, those requirements in the CCDA discharge summary, some of that informed the new ballot that, as she mentions, coming out in January. So that's that feedback loop to improve the standards, which are based on USCDI, which go back toward regulation and get referenced as future versions and so forth. So this is actually showing how that feedback loop helps. One thing I want to point out to folks, and Katherine touched on it, the continuity of care document, the consolidated continuity of care documents. CCD is one type of document, as Katherine mentioned. The CCDA standard actually has 10 different document types, 70 different sections, hundreds of different entries, and it's all open. It's kind of like Lego blocks. I use this analogy a lot. You can decide what Lego blocks you want to play with in your document type, and that could be different for an encounter-based summary versus a patient level summary. So one thing folks need to think about is that hopefully your vendor, your implementation, and this is part of the guidance in that version 1 guide, we need to make sure everyone thinks about, if you query for information, you not only get a patient summary. Here's everything a snapshot in time, but also the last encounters, because you may want to have this from physical therapy or this information from some sort of other health workflow that may have not just been the discharge, but the follow-up work as well. So thinking about what is useful information to share, but the data quality work that we're doing is, as Katherine mentioned, the version 1 that was published in December of last year, folks are taking root of that. We started launching that in July of this year, and I'm happy to report we have 51 organizations right now that have signed on to be what we call supporters. Those folks are supporting the work. They're asking their vendors to implement it. Maybe they don't control the technology, but they know what they need to try to improve. The data usability guide's 40 pages, but the real heart of it is only 6 chapters, 6 sections that give basic guidance on how to improve that usability. It's something that should be implementable in 18 months, because this is not a one and done. This is a ongoing sprint that we're going to keep leapfrogging. We're already working on version 2 commentary. And it's funny because the taking root, we're having what we call roundtables of those 51 implementers, supporters, and sponsors, FAHIMA being one of the sponsors that we have, actually meeting every month to figure out what should we do to support the community. What do we need? Technical assistance, tooling for testing, all of those things. But it's funny, some of the comments I've been asking them to make on some of the things like scorecards, how we're going to hold each other accountable, how are we going to report progress, we're finding some of those are suggestions for version 2 already. So these are kind of the process that we're doing with the data usability taking root, version 2.0 work that's already begun. And we're going to really start doing the bulk of the writing next year and put it out for public comment in July. And then it'll be available sometime late 2024 to start having folks that have already started taking root of version 1 start thinking about what version 2 will bring.
Kel, what would you add to the how we improve content usability?
Well, first of all, I want to thank both of you for the efforts to standardize things on the front end, because then that comes down to us when they change EHR vendors and we archive the legacy stuff. Having standardization come out the back end as well, going in the front end, makes a huge difference for us on projects. Something that Didi and Katherine both talked about a little bit earlier, I think from a usability perspective, we really, really strongly recommend too, the archive side, people doing it discrete, the discrete components of this. The fewer documents you have, a CCD is different. We take the whole CCD in, but when you're looking at like the whole database that we take, storing as much of that discrete as possible, because as you build out a USCDI or you build out the designated record set with the financial components, sending those from an interoperability perspective is going to be much easier and usable when you've got those discrete components. And both of you kind of mentioned that the pieces and parts, the metadata, date timestamps, all those little things that go along with not just the result of the CBC that you were mentioning, Katherine, but the pieces and parts that go with that, who ordered it, the date time they ordered it, the result time, all of those little things are critical, because they're going to need to go along. If it's available, it needs to go along when you start sending it through the interoperability and making it usable to the other person on the other end, especially if they want to trend something. So, but I wanted to, if we talk about usability, the efforts you guys are making does make a difference for us. So thank you both for your work on that.
I'm going to jump into kind of a multi-part thought process of what are the existing emerging regulatory requirements impacting data quality and usability, but also as we're looking at all the regulatory stuff, what enhancements should we be looking toward to give, like all this feedback you've already given, but continuing to into the future legislatively, regulatorily, or just industry-wide, where we should be moving forward to enhance. And I'm thinking of Katherine, ADT, the event notifications became a requirement through the CMS first interoperability rule. And I think you've done a lot of work around that as one example.
We have done a lot of work on that. Once again, our physicians were angry because they were being overloaded with information that was not useful. But we began to look, and we looked at the DirectTrust event notification standard, which is very robust and contains clinical information to help them, and also contains context that allows them to route the message to their scheduler to the highest level of individual that can manage it, so that the PCP doesn't get all of those messages. We worked on that. We got the hospitals throughout the state of Texas to adopt it, and everyone's happy. So if you have not adopted DirectTrust event notification standard, please do. Adopt it to send your messages and adopt it to receive your messages, so your primary care physicians are not frustrated with information that's not meaningful. So that's my biggest one. Now, another one, Susan, real quickly, is the DirectTrust directory project. One of the wrinkles that we're having in the community is people cannot find the PCPs. So DirectTrust has done a lot of work recently on directory improvement so that it's required to be shared and the structure is more defined for the health HISP. But the HISPs are going to depend on all of us to do the right thing, like include the MPI, the legal name, etc., so that we can share that information clinically. And the third one is adopt AHIMA's patient, not patient anymore, naming framework, so that you can find providers in the DirectTrust HISP, DirectTrust directory, and that you can find patients when you share information across the continuum. That's it.
Those are great ones.
three.
You're ready. Okay, Cal, what would you like to enhance or develop going forward into the future?
I think probably for us is working closely with Sequoia and ONC. So we've had some interaction with them to date, just as reminders that the designated record set includes the records that are sitting in the active archive. That as the Cures Act, though there is not specific language around the active archive or the data that's sitting in there, we had to look at this very closely early on to realize that even though there's not specific language, we have and house the designated record set component of that. So we, making sure that the Cures Act, that we are compliant, that our systems built out to support US CDI all the way right now. I know that version 3 is they're looking at that for as a base standard now. And the 4 is going to come out shortly, the draft of that. So we have, as we look at that and interoperability with FHIR, because we do send FHIR transactions now with our government. And I expect that we will, we've had some of our current customers as well. We've had several meetings now about using the data to send the FHIR transactions for that. It's just something I think that we have to, as the vendor, on the vendor side of this, really pay attention and work closely with customers and with our representatives, whether it's Sequoia or ONC, to make sure that we are supportive of those legislative changes that come down the pike, because of the completeness of the record includes the data that we actually are housing. I think what I would like to see, and I don't know that it's going to happen anytime soon, but one of the things we have to focus on is the unique identifier for patients. As patients start looking at accessing their own records across the continuum, we have to figure and I think solve for that, which is a huge issue. We talk about it now with our current customers, but it does need to be raised up. I think it's going to have to be one of those things that's raised up to a much higher level than, just at the vendor level. I think it's going to have some sort of regulatory requirements around that, simply to prevent violations of HIPAA as patients, especially when you've got data storages or data access from multiple systems. So if I see 3 different doctors, I want to go to one portal as a patient, and I want to see all my data in one place. But that means that those organizations somehow are going to have to know that it's me, because right now they have individual identifiers. So there's a lot of work to be done with that, but that's what I would like to see.
I will amen that and not go too far on it, other than DirectTrust has a Pearls work group working on that, of one of the many initiatives out there trying to come together until we can legislatively address that. And I'll stop with that there and move to Didi to give us her thoughts on enhancements for the future.
I'll do this real quickly. So for those who have been following along, the 21st Century Cures Act, both of you mentioned that already, that kind of set the tone back in 2016. So regulations continued to build off of that. As mentioned earlier, the 21st Century Cures, the recognized coordinating entity, which Sequoia is part of, and as the contractor with ONC, the qualified health information networks that are coming on are also going to inform the governance policy frameworks that our regulations will hopefully point to as well in the future. So we're hopeful that building off USCDI, the Data Usability Implementation Guide version 1 was based on USCDI version 1. The version 2 that we're going through the writing process now for is going to probably leapfrog to version 3, or maybe even some of version 4, because it does include some of the lab components that we may need. So I think that the regulations will help push us by having the implementers have to with a carrot and stick. I know the HT1 regulation that was put out for public comment did mention the USCDI version 3, and I know that it's imminently going to be published somewhere along the way very soon. So I do hope that working with regulation, with policy frameworks, whether it's the QHIN technical framework as part of THSA, or if it's care equality, DirectTrust has a policy governance framework, whatever those are, helping inform those so that we can do things like, how do directories work together? How do we keep these things secure? Those are the policy things that are right now we still have to work through to make sure we reach consensus on. I think the standards are there, but we do need to make sure the policy frameworks continue to evolve to allow for those new innovations, research, things like that are going to come in the future.
I will say amen to that. And one thing I often put into my presentations on advocacy is it doesn't have to be anyone specifically, that you don't have to hold a certain title, position, company to be part of these feedback loops. So I will just echo that. We have 1 minute. Any final word that we need to get in there before we move back on to the next group?
We all have a part to play.
Yes.
We all have a part to play. So I challenge you to figure out how can you best help move interoperability forward.
Yeah, get involved, follow what's going on so that you're not behind the 8 ball and struggling to catch up. Figure out what's going on right now, contact the folks that you see here so that you can get a good start with this, and then you know how to stay on top of it, because there are a lot of changes coming.
And anyone who wants any information from what's going on in the state of Texas, glad to share and glad to get you involved. If you have any work in Texas, you can join our collaborative.
Awesome. Thank you all. I love this panel so much. Can't wait to see you in real life sometime soon. And I think we're out for Carol to come back on.
You are panel 1. Thank you so much. I appreciate that. That was great. You can go off camera and go on mute if you would. Thank you.